All right, great. Hello, everyone, and thanks so much for joining us for this very first episode of Heart of a Woman. My name is Dr. Yewande Austin. I am honored to be a 2022 Woman of Impact nominee. I wanted to host a series of episodes that would help us learn a little bit more about the myths, the mystery, and the management of cardiovascular disease. And I'm so deeply honored for the very first episode to have a friend and colleague with me, Dr. William A. Cooper. Everybody give it up. This is pre-recorded, so we're giving a virtual, a
Thank you,
virtual
Yewande.
applause. Absolutely. Dr. Cooper is more than a cardiothoracic surgeon. I credit him with saving my life. But first, a little bit about Dr. Cooper, and then next, how we met. And then we'll take a deep dive into the critical role that communication plays in improving health outcomes for patients like myself. So Dr. Cooper is the former medical director of cardiovascular surgery at Wellstar Kennestone Hospital in Marietta, Georgia, where he performed over 6,000 surgeries, including the hospital's very first open heart surgery. He's taking the lead perhaps of one of the greatest battles in the history of our nation, though, and that is the war on heart disease. He exemplifies an understanding as a medical practitioner that health and education equal power. Today, Dr. Cooper has elevated his mission to improving access to healthcare through his company, PRIMO Health Partners. He is the founding chairman of an organization that is improving access through what a new world that we have all become very closely familiar with, and that is the virtual world, improving health outcomes by providing immediate medical attention by connecting with Dr. Cooper or one of his capable medical practitioners to address your immediate needs in a world that is ever changing, not only driven by COVID, but so many other interconnected health issues that we're quite honestly afraid to address because we're afraid of being in medical facilities where our exposure to COVID and other issues is more prominent. So we're going to get to more with Dr. Cooper in just a moment. But first, I want to tell you about our story. In 2012, I was at a professional event where I started experiencing rapid arrhythmias. I wish I could say it was the first time, but it wasn't. I was one of millions of heart disease survivors that had seen the signs, ignored them. Why? Because I was too busy, maybe a little bit too afraid to deal with the truth. But that night, I was very lucky that two angels intervened, called an ambulance. By the time I was loaded into that ambulance, my heart rate was over 230 beats per minute and climbing, to which the EMT at that moment cursed out loud, and I thought my life was over. Fortunately, he was able to get a needle in my veins in time to reduce my arrhythmias and get me to a hospital in a city outside of where I lived, only to find out from the doctor on call that night that I had what he called a borderline heart attack. Shocked, but yet not shocked that I had ignored signs that my body had been giving me for quite a while. But how do we deal with this? This was really my next thought. How do I deal with it? Well, he told me to go back to the city where I lived and seek advice, but his number one recommendation was heart surgery. Well, when I went to that practitioner, I was told that day that I had one of two choices. Either that I could get on blood pressure medication, which I wasn't really a fan of. Medicine to me was a Band-Aid to a problem that I thought needed to be solved. Or I could have heart surgery, specifically a cardiac ablation that would sever the electrical wiring in my heart to prevent the supraventricular tachycardia, right, or the rapid arrhythmia from hopefully leading to a heart attack again. Well, when she told me those options, it was a lot, of course, to take in because I had unfortunately become a member now of a club that nobody wanted to join. I've now become a heart attack survivor And I needed support. I needed someone to not only listen and validate what the best choice was, but to really act like they cared. And unfortunately, that day, I don't know what was on that doctor's heart, but it was not my heart or my well-being. Because what she said to me when I asked her what she would do with a family member of her own was, it's your body. Get back to me and let me know what you want to do. I got to tell you, that didn't sit really well with me. And so I happily took myself on out of there and said, that's not where we're stopping. I went to a second, third, fourth, fifth, sixth, seventh opinion until a dear friend of mine, Tara Coit, recommended that I look up her friend, Dr. William Cooper. And I said, what do I have to lose? Well, Dr. Cooper, you may not remember, but on the day that we met at a cafe outside, I remember with my file of all of my charts, my EKG, my ECG, my everything. And I didn't really know how to read most of it, but we sat down in front of a cafe at a table. And you said to me within less than 10 minutes, Miss Austin, I don't know why this cardiologist told you you had a borderline heart attack, but you had a full heart attack. And you need to go back to them and you tell them that Dr. Cooper said, you don't need to be on medication. You need to have surgery or your heart could expire. It's not a matter of if it will, but when, if you don't get this surgery. And I said to you very politely, we didn't know each other well, thank you. Thank you for telling me the truth. And I remember you asking me again, do you understand what I just told you? And I said, I do. And thank you for telling me the truth. I don't have any more tears to cry. I'm afraid of being afraid. I really needed the truth to know what I needed to do to take the next step in my healing and recovery. And there began a long relationship based on this simple thing that I think doctors still struggle with, and that is how to tell their patients the truth, the very thing that could lead to their survival and healing. So one, publicly, because I've never done that before, had the opportunity, publicly want to thank you for leaning in and being a truth teller that day and for being a major role in saving my life. Two, let's get right to it. Why do doctors struggle with telling their patients the truth?
Well, thank you so much, Yewande, and for having me on this program. And I'm really honored that I am your first guest. And it's so good to reconnect with you. I will tell you that, communication is a big issue in healthcare. And I think one of the things that's like so many other things that I think are missing in our training as physicians and young doctors is how to do that, how to communicate. How do you sit down with someone and give them bad news? Well, at the end of the day, we have to step back and say, wait a second, I am a human being. Okay, there's all kinds of ideas, thoughts, analogies going through my head, perhaps not only for me personally, but perhaps for a loved one, a family member, a friend who could be in this same type of a predicament. Okay. And so I think it's important to understand that medical education doesn't include communication education. Okay. And so I've been one to say this for a number of years. Most doctors don't know how to communicate. And I'm going to say that, and I'm going to say it very, very firmly on this very public program that I will have on my sites and your sites and everywhere else. They do not. I see it every single day. I've been in this business for 30 years. And it's very interesting. I'll just give you one anecdote here. Okay. I had a young physician the other day. I was in the hospital and I had a patient that I needed input from a specialist, okay, just to give me their input. Now, of course, it's a formality for me, but I also want to give the patient the benefit of having had a different perspective, okay? So they gave their opinion, and essentially the opinion that was put in the chart was the same one that I'd already given in my opinion. So I called him up and I said, well, I said, I appreciate you seeing the patient. This is very helpful. But I'd like to get a little bit more granular, a little bit more specific. And, so then, he goes on, this is a young physician. He goes on with this little diatribe and he doesn't know who he's talking to. And interestingly, when he finished, I just said, okay, you know what? Thank you very much. I appreciate that. But what I heard in his voice was a lot of a really uncertainty in his voice, not really knowing how to say what needed to be said,
Yeah.
which is, hey, Dr. Cooper, I really don't know, you know,
How about that?
or
I don't have the answer.
or you know, or we revert to the exactly, or we revert to the there's no data. And now look, I've been in this business for a long time. There's plenty of data. It's just a matter of how you want to interpret it and understanding that there's conflicting data. Okay.
Mhm.
And so I just went on about my business. I've learned in my 30 years, and I have grown and matured in this business. I have nothing else to say. I have nothing else that you can add. So end of conversation. I said, well, thank you. I appreciate it. Have a fantastic day. Just like that.
Mm.
And so interestingly, I checked my phone several hours later.
Mm.
And this is, I didn't know of you. I didn't know the color of his skin. I could care less. You know, I just sounded like a physician on the other end. I mean, even his voice, he just sounded like another person. I don't care.
Mm.
But I got a voicemail later. And it said, Doc, I just want to make sure, I talked to my partner and some other people, and, we really just don't have any data. We don't know. I said, I didn't respond to the voicemail. I said, that's fine. It's okay. So now I'm assuming, and I know this, my intuition is telling me this is true, that he probably then did a little bit of background and research on Dr. Cooper. So lo and behold, interestingly, I go up to now talk to the patient and the family, and there's a room full of family members, okay, to talk to them about, okay, we're going to have to do surgery, and we're going to do that surgery tomorrow. And lo and behold, here this young doctor comes down the hallway. Hey, Dr. Cooper, I'm Dr. So-and-so, and I'm the one you talked to on the phone. I said, okay, great. I said, come on in, have a seat, sit down, you might learn something. Mm-hmm. And so, he sat right beside me as I went through and told the family, really just had a conversation with the family and the patient. Okay. Just like you and I are talking right here, Yewande. Yeah. So I say all of that to say that they haven't been taught how to take off the white coat, be a person, a humane individual first, connect with that person on the human level. Right. You are talking to another human being. They have no more expectation of you than you have of them. Let me say that one more time a little bit differently. They have no more of an expectation of you as a physician than you have of them as a patient. Just be a doctor. Yeah. Be honest, be open, be willing to explore, be empathetic. But unfortunately, our medical training doesn't really teach us that. And it takes years sometimes for practitioners to learn how to do that. Now, in your case, in what you described, there are so many other influences that were around in 2012. Okay. If you go back to 2012, at that time, 29% roughly of physicians were employed physicians, meaning they worked for a hospital system or a large multi-specialty group or a corporation of some type. Okay. That number is now 70% in 10 years of physicians and growing are now employed. Okay. Wow. I'm actually writing a blog about this that will be released in 2 days on Wednesday, Doctor's Day. Okay. That talks about some of the frustrations. Now, if you read the paper, everybody talks, doctors complain about the EHR. That's smoke and mirrors. It's not. Look, we use technology every day. It's at our finger. It's getting better. It's not perfect by no stretch of the imagination. It's getting better and better and better every day. And so you hear people complain. Let me just give you let me drop a bomb in here, okay? Because that's what I do. All right. If you give some background on the EHR, well, the underpinning of the frustration of doctors with the EHR is the fact that they are volume dealers. They don't have time. They don't have time for the patient. Right. They don't have time for the documentation on that particular patient. Why? Because they are compensated, and this is not me saying that, they're compensated on volume, not value. Okay? They are compensated on what they do, which is the more people they can see, the more they're going to get paid.
Wow.
Look it up yourself. You don't need Dr. Cooper to sit here and pontificate about it and come out. No, these are not ideas. This is what the data shows, that 90+% of those employed physicians in particular are compensated on productivity.
Wow. So Dr. Cooper, I have to intercede for a moment because
Sure,
you've got
please.
to take this interview in a whole nother direction.
I gave you a lot there.
No, which
I gave you a
I
lot.
should have expected. I don't know why I was
Absolutely.
not ready, but I like it. I'm here for it. I'm here for
Yeah.
it. So let's talk about this then. If we're talking about volume is more important than quality of life, quality health outcomes, right? Quality future for patients that are seen, what happens to the moral implication? I mean, when did the priorities change from quality of life and commitment to preserving life in over profit, right? When did the benefit, I'm sorry, when did the priority become profit over people, especially in the medical profession, where you all take a Hippocratic oath that you will value every life that walks in that door, despite differences in race, creed, faith, color. And then furthermore, where is the disconnect in understanding that if you improved quality of health care, then you would invariably generate more revenue, right? Maybe by word of mouth in those patients being happy with their care and bringing in other patients and other accolades that a medical professional could get, not seeking, but could get from saving lives as opposed to the quantity of lives that they've cared for. Where did this?
Yeah, there was a lot packed into that.
Yeah.
When did this begin?
Yeah.
Well, when I examine, from my, 30 years in healthcare, since 30 plus years now, since 1986. And if you look at the regulatory changes, the regulatory environment that are largely driven by government intervention, okay. You look at my profession, thoracic surgery. When I first knew about heart surgery, when I was in high school in the early 80s, heart surgeons used to get paid on the number of grafts that they sewed onto your heart. So guess what? If you go back and look at data from that era in the during the 80s in particular, somebody would go and have a bypass operation. They may have 6, 7, 8 bypasses. Why? Because the surgeon got compensated on the number of grafts.
Mm.
Oh, they may put a target on my back for saying this, but I'm just telling the truth. Okay. I'm only going to give you the truth. Yeah. Nowadays, you hear that the most common, that number on average is probably about 3 bypasses. Why? Because they're doing what needs to be done. Okay. But nothing more.
Okay.
Okay. Now, that hasn't shown to be having any impact on, well, if you do what needs to be done, if a patient needs 6, I do 6. If they need 3, I do 2, 3. If they need 2, but it's awfully strange that the mean number when you were getting paid per graft went from 6 or 7, 6 or whatever it was back then, now down to 3. Okay. So, and then you saw in the early 90s, I'm just going to give you kind of a historical, early 90s, you started to have the emergence of managed care organizations. Why were they doing that? They started to see that, or the government started to see that, if you just go back and look at the trend for spending on healthcare, it's unsustainable. Even now today, you would say to some extent, the pathway that we're on, I don't know how we're going to sustain this indefinitely for sure. Okay. And then you think about all the other pressures on the economy and our government, financing of our government in general. Healthcare is one of the biggest expenditures. Okay. So you start to see managed care organizations come into play. Okay. Then you started to see, you may remember Hillary Care. Everybody's going to get a card. Okay. That got, rejected summarily. Okay. So then Bill Clinton gets elected. Later on, they come in with more regulatory changes. Now, back in those days, used to hear about, I forget the term, but where, you hit a certain number, it doesn't increase your income, so almost like a cap on the productivity thing. That went through a whole, and I'll think of this later and I can give that in the reference when we post this on our sites. But you had those kind of changes. But all the time now, you got to remember, this is over years. You got all kinds of people looking at healthcare And they're looking at the fact that we've gone from $500 million in the early 80s to now, today, in 2022, over $3 trillion in expenditures for healthcare, okay? And so, and then you think about, okay, the government comes in and says, well, look, okay, and I totally get this. All right, you guys need to get together. Doctors over here sending a bill to a government entity, Medicaid, Medicare, the hospital sending a bill, the lab, the pharmacist. Wait a second, why don't you all get together and consolidate? So rather than compel you to do that through some kind of a mandate, you do it through what? How we reimburse you and how we pay you, okay? And some of my internal medicine and primary care colleagues call that, essentially an assault on primary care. It is very, very difficult today for any doctor to go out like my vision of when I was going to come out and go into healthcare, hang a shingle and say, I'm Dr. William Cooper, I'm a heart surgeon, and make a living. No, it won't happen, okay? The reimbursement is not there. So this has been a gradual change and evolution. So now you've got, okay, the changes now, the differential between what a physician gets paid in their office for doing a test versus what they get paid if they were part of a hospital. So there's almost a 30% difference. So it makes sense that doctors are going to go to the hospital because A, they don't have to incur the cost of managing that and knowing that for the same type of testing in their office, they're not going to get the same reimbursement. And the hospital is now going to offer you all of that management capability and give you a nice salary. But guess what? That salary is still based on what you do. It is not necessarily based on the outcome or the quality that you produce. Even though, and here's a big disconnect. I was just reading an article on this yesterday. Insurance companies, the government, all payers, you will hear this term if you go and look it up, value-based payment, okay? In the government side, it's not necessarily so much a bonus as what it is okay, look, if you hit this target, we're going to pay you at a certain level of outcomes and care. And if you don't, then you're only going to get it reimbursed at this level, okay? So government payers, private payers are now ACOs, you probably heard of accountable care organizations. That's all about value. That's all about what you talked about. Because the value equation, okay, includes the outcome, okay? Having a good outcome, because we know if good outcomes are, if the outcome is good, the quality is better, the care has been appropriate, and the cost should over time go down. So you got a great outcome at a lower cost, okay? Now, here's the very interesting thing. Although most healthcare systems are tied to some kind of value-based, if it's not even a government, you may hear about alternative payment systems, MIPS, value-based care. There are all kinds of things out there now that are various manifestations, but they're all trying to drive one thing. And that is they're trying to drive the quality of care, okay? I applaud that, all right? But then you've got another factor that's embedded within healthcare systems, which is the vast majority of them compensate the people who produce, who have the greatest impact on that, on volume. They don't necessarily compensate. Less than 10% of the compensation in most healthcare systems is based on the quality. There'll always be some quality component to the compensation, but for the most part, it's what we call, it's a RVU-based system, relative value units. And basically, let's just give you a simple example. What I do as a heart surgeon, for example, if I do a bypass operation, that's been given an RVU value, a relative value unit. Say if it's 30, and then for each one of those relative value units, there's a dollar number figure that's put on one. So let's just say, for an example, in this case, it's $60, okay? So you do a bypass operation, then the RVU for that is going to be, the dollar value is going to be $1,800, okay? All right, okay, and so the doctor is then paid on how many of those he can do. So what's that? I mean, it's just natural for them to gravitate towards what? Doing volume. Why would a system do this? A system, and here's the it's very, very complicated and complex. Because the systems, although the majority of them are not for profit, they are good. In a lot of cases, they're acting like for-profit corporations.
It sounds a lot like it. And now you got me really rethinking my entire care from the very beginning of the situation, because now, can you break down for me what an RVU would be comparing my surgery versus if I had become a patient that was on blood pressure medication then for the rest of my life? Or is that equitable? Does RVU also apply to how much medication I would have been on? And would the doctor have been credited with keeping me on a prescription for the next 10, 20, 30, however many years longer that I lived? Did the two even equate?
No. So the RVU is based on the actual provision of care. Okay. So it's kind of, it's not a normal comparison, but also the other issue there is that the assumption in what you just said is that you can uncouple the two. That's either or. It's not an either or, it's both and. Okay. Because the fact of the matter is, with an ablation and with the problem that you had, the SVT that you had, you're going to need an ablation in addition to ongoing medical therapy. Okay. And so it's, you can't uncouple the spectrum of care that you require. Okay. So, but yes, there is an RVU number that is applied to you having had that ablation. Okay. But there's also a relative value unit of you having come to the office. Okay. And having had, in what we call an E&M charge, was an evaluation and management. Okay. And those are then tiered based on the level of interaction with you. So if I have to strip you from head to toe, complete examination, order test, and go through all of those things, then that's going to give you like a level 5 intervention. Okay. And so you would bill at a level 5. There's a number that goes with that. Yes. And in a lot of cases in those E&M charges, most contracts will say there's a fixed price for that. Okay. Just as it's apples and apples, because it's either RVU or it's a fixed price that they're going to reimbursement they're going to give you for that particular E&M charge. Does that make sense? Okay, good.
It makes total sense.
Okay, but the underpinning and the thing that you need to understand, okay, and this is one of my issues and one of the reasons why, I choose to be an independent contractor. I'm not in the rat race anymore. Okay. I love going to places like I'm here in Denver and Kansas City, places in Georgia and all South Carolina, wherever I may be, because in a lot of cases, I'm just there on call and I'm waiting for something urgent to happen, or I'm just there to see people in the hospital who may need my services. I get to spend time with them. I don't have a 7 a.m. meeting. I don't have the noon meeting, the meeting just to set up the next meeting, talking about these quote quality initiatives and these all of those things are important, and that may be for some, but it just wasn't for me. So now I have that time to sit and spend to really get to know you as a patient, to really take care of you, give you the top quality I can give you. Okay. It's not a volume deal for me. Okay. I'm paid based on a daily basis, a daily rate for my time and availability. Okay. And quite frankly, that is a bargain for most hospitals, honestly. And so now, am I advocating for a shift, this way? But here's what I will say. I feel that, I've been in healthcare for a very long time, and I see and hear a lot of frustration. I love going and sitting in doctors' lounges around the country, the places that I have that I work with, because I hear all of the things that, literally I used to go through. I mean, here it is right in front of me. Okay. And so you really have to understand the complex interplay and interaction of all these various inputs to understand the things that, back to your very basic fundamental question, why do doctors have such a hard time telling the truth? Or why are they moving? They don't, it may not have been that your doctor had a really bad attitude that day. She may have had 20 or 30 more people on her calendar schedule. And she just didn't want to get into it with you, because she knows that if she's got to spend another 15, 20 minutes with you, her day is backing up. She's got to do all this electronic medical record stuff at the end of the day, or between.
But Yewande may not be here today.
That's right.
Had taken the time to do what she had committed to doing professionally and morally.
Right. So I'm just giving you the reality
I
of what,
get it. I get
yeah,
it. But,
yeah.
and you just bringing up all kinds of emotions for me all over again, because there are so many times throughout my early intervention that I felt like I got the short end of the stick. I mean, I think about not only that second engagement now with a medical professional who I am pleading with to give me a piece of her heart that day, to save mine, to know how to save mine. I was dismissed. When I think about after I did have the ablation, which let's not get into talking about how much I've heard the ablation has now changed, because that day it was just outpatient surgery. I know you know all about that. And I was scared to death. What you mean you're gonna open my heart? I'm gonna leave the same day, wide awake on the table, by the way. We're not gonna get into all of that, because years later, of course, I hear from another friend who I tried to prepare of what to expect with a cardiac ablation, as gently as I could explain to her what it's like to have heart surgery while you're wide awake, nightmare on Elm Street. And for her to come back to me a couple of days later to say, Wandy, I talked to my cardiologist. He said she was awake during the whole surgery. They don't do that anymore. And I'm like, well, why was I put through that nightmare, right? So there's another infringement, right, in my experience. And then one of the very last, at least in that first chapter, was when I experienced complications from my heart surgery, went to my cardiologist and said, I'm having problems here, right, in the groin where they went in with the catheter to my heart, dismissed it, only a few days later to wake up in the middle of the night, struggling to breathe, only to find out that a pulmonary embolism had formed. And once again, I had been dismissed. Now, I'm sure that there's a reason for that also, that you may be able to reconnect with what he could earn or what he couldn't. I don't know. What I do know is that if I not had doctors who cared like you, I wouldn't be here. What I also know is that there are too many patients just like me who trust what the doctor says and don't know how to fight for themselves, to fight for their rights, who have died, who I know are no longer here because they didn't do what I did, which was get a 7th and 8th opinion. They didn't do what I did in going to a doctor saying, something is wrong, I need you to check it out, and check it out again. And they didn't. And they're no longer here. And so that brings me to ask you, how can patients be better advocates for themselves, considering this mind-blowing reality that you have just shared with us? I'm sure all kinds of minds are blowing up right now around the world and jaws are like dropping on the floor. How can we be better advocates for ourselves in the fight against cardiovascular disease, knowing the uphill battle that we're climbing with this conflict between moral obligation as cardiologists and the business that has developed now within pharmaceutical care and healthcare?
Yeah, that's a great question. I do want to address one thing for you, because it goes back to the whole communication piece. If you recall, when you were admitted for that pulmonary embolus, yours truly came to visit you.
You did.
And if you also recall, while I was there visiting you, 2 young doctors came in. And if you recall, you remember they stood there like this, very kind of mum and a matter of fact. And I just observed, and you didn't tell them that I was a doctor, and I didn't, and in fact, the hospital that you were admitted at, I was actually on faculty and staff there. Okay.
I remember now.
You were at Emory Midtown Hospital in Atlanta, Georgia, at Crawford Law. I happened to still be on faculty at that time with Emory. And so one of the things that we observed during that interaction, and I just told you, I said, you were asking the nurse when she came in, hey, are they going to come around? And, and then sure enough, a few minutes later, here you had this, I think it was a hospitalist and then an intern or resident or something. They were so uncomfortable. I remember pointing out to you that, they just didn't, there was no connection there. And quite frankly, I think their insecurity was with themselves. Now I don't know if the nurse had gone out and said, do y'all know Dr. Cooper sitting in there or what? But if somebody said that to me, I'd say, oh, do you got a doctor in there? Maybe they can help me figure this out. I'm going to go in there and shake their hand and say, hey, I'm Dr. Cooper. Who are you? What do you do? Let's talk about this.
Mhm.
They were so uncomfortable with that entire interaction that I really felt sorry for you.
Mm.
But through my connections and network, I was able to connect with the people there and give you the information that you needed. Okay.
Yeah.
And it's unfortunate that the people who were really charged with taking care of you couldn't do that.
Yeah.
And it seemed as horrible as that was for you.
Mhm.
It's not that hard. It's just not that hard, but they made it hard. And it
Yeah.
was so disappointing for me. So I want to say that just to close out the whole communication issue. But second, to get to your other question, how do we advocate for ourselves?
Yes.
And this takes me back even further in our conversation, which is just so you know,
Mhm.
one of the reasons why I started PRIMO Health Partners was because of you. I
Mm.
mean, it's very frustrating to me, because my personality is one, I'm very gregarious. As you know, I've got over 10,000 contacts in my phone and people call me. A lot of them patients are really surprised when Dr. Cooper said, "Hey, you want my cell phone number?"
Mm.
And they're surprised when I say that because why? I mean, I don't care.
Yeah.
I mean, God Almighty, I mean, none of my patients have ever abused that,
Mm.
never.
Mm.
And it's only when they find themselves in a situation where they're confused or they feel like they're not, certainly if I'm taking care of them, being able to communicate effectively with their care team. And so all of those things over the accumulation of all of that over the years is why I started PRIMO Health Partners,
Wow.
a professional resource for independent medical opinions. Okay.
Mhm.
Now, getting back to your question about how do we advocate?
Yes.
The answer to the question is advocate.
Mm.
Ask the questions.
Mm.
You hold people accountable. Don't take no for an answer. Okay.
Okay.
Get a second opinion.
Yeah.
Okay.
Right.
And there's some data out there, that says that suggests that about 30%, and this is on the surgical side,
Okay.
30%, when somebody goes and gets a second opinion, 30% of
Mhm.
recommended surgical procedures are very likely unnecessary.
Mm.
So think about 30% of elective surgeries, gallbladder, breast, biopsies, all kinds of stuff,
Yeah.
are deemed perhaps unnecessary by the second opinionist. Okay.
Interesting.
And you just imagine how that could lower the cost of healthcare, lower the cost of complications, because every time we intervene, there's the possibility of a complication. In your case, ablation. Now I got a pulmonary embolus from a clot in the vein that formed, where they access my veins.
Mhm.
So all of those things matter. All of those things matter. But once again, when you're in a system, and I'm not advocating for socialized medicine, I'm just advocating that we rethink this thing.
Mhm.
I think a couple of targets, if you will, we got to get away. I'm not a big proponent of this productivity-based compensation,
Yeah.
because here's how it works.
Mm.
And in fact, Match Day was March 18th. Match Day, if you don't know what that is, that's the day that all the fourth-year medical students, they go out and interview and all this. They learn where they're going to go and do their residency, their postgraduate training.
Okay.
Okay.
Mhm.
And so when they come out of the residency, they're going to go, and those are going to be salary positions because they're subsidized. Even if they're in a private, if they have a residency program, it has to be, if it's accredited, then it's going to be subsidized by the government through Medicare payments. That's a whole nother complex system. It's a good
Okay.
system. I like that. So they're going to get a salary for 2, 3, 4 years, however many years they're considered a resident. Okay.
Mhm.
Then they're going to go and get their first job. And 90% of them are going to get a job offer like this. Well, we'll give you 2 years of base salary. And now, if you do so much, see so many patients and do so many procedures,
Mhm.
on top of that base, you may be eligible for a bonus. Okay.
Mhm.
That's the first 2 years. The third year, now you're going to move, that base is going to go down, and it's
Okay.
largely going to be based on the productivity over a historical over the last 2 years that you've been there. So then they're going to base your base on that.
Wow.
Plus product. So it's a very likelihood, if you don't continue to, you can't really get in a situation where you actually increase your income, because there's a ceiling. You're
Mhm.
chasing the carrot, you're chasing the rabbit or the
Right.
carrot, and you'll never catch him.
Right.
The rabbit's running a 4.440 and you're running a 4.6. He's just that little bit ahead of you.
Right.
But guess what? You're in there breaking your back, breaking your neck, trying to produce, missing out on the opportunity to be an advocate, a real advocate for the patient in in situations, and actually be a part of that real quality, that real return to wellness. Okay.
Yeah.
All right. And so you're missing out on that. But guess who benefits? Well, the hospital system or whoever you're employed by, they're going to benefit because they got all of you all out here
Right.
chasing the carrot, chasing the rabbit. And again, you can never catch that rabbit. Okay. You won't catch him.
Yeah.
All right.
So a system that we depend on to save our lives every day is at war, essentially. And there is no way really for any of us to come out on the other side of this war standing unless we have access to this information and we recognize our power to actually determine our own health outcomes. What I call partnership. You may recall that I started the first healthcare diversity program in the country at Virginia Commonwealth University, and teaching students how very important diversity principles play in improving health outcomes. It was one of the most important lessons that students came to me every day to say, they don't teach us this stuff. You know, the doctors are not teaching us how to communicate. Doctors are not teaching us how to practice empathy. Doctors are not teaching us how to empower our future patients as partners in their own diagnosis and healing. And so this could be, I think, a 4-part series. And I am pretty sure that we are going to need to continue this in some way, and we may need some security after this. We'll talk about that later, because you have just blown up a whole industry in the middle of COVID. There is so much conflict that is out there right now about whose lives are deemed as being valuable, who are getting equitable access to treatment for COVID, who is being turned away, who has had access to the vaccines in their communities, who hasn't. But coming back around to cardiovascular disease, we know that by the year 2030, well over 23 million people around the world will die from cardiovascular disease. But we also know that 80% of those cases were preventable. Talk to me about, with a new awareness that we have about diversity, equity, and inclusion, talk to me about historically marginalized communities of patients, how much more they are at risk for cardiovascular disease than others. The numbers are pretty close between, let's just say, African-American, Hispanic patients compared to that of white, but still you see this disproportionately higher rate of patients that represent, again, historically marginalized, or what we would call even BIPOC today, Black, Indigenous, people of color, that community. Talk to me about why those disparities exist and how PRIMO is helping to bridge the gap in those disparities with access to healthcare.
Great question. And every time you ask me a question, I have to go back and comment on something you've already said.
Okay.
So when in your program, for example, your diversity equity program at Virginia Commonwealth,
right.
Yes, it's very, very important. It has a huge impact on outcomes and the care that we deliver.
Yeah.
But let me ask you this question: who cares? Because, and then I'll say something, and I say that very, very seriously. Who cares?
Yeah.
Does the system really give a damn? We got plenty of research. We know the issues, but so the question is, what real incentives? Because it's all about incentives to me. I've seen it really exist within a healthcare system to make change and move the needle on that. So you've got to either rely on the beneficence of someone who's been put into a situation where it's all about volume. And they've got to have a very, very special sense of beneficence to be able to say, wait a minute, this is more to me than just the next patient. Right. This is about what that patient looks like and serving their needs. Okay. So there's nothing in the, so we could talk about this all day long. Yeah. But until the hearts and minds of people, if that's what we're relying on, because right now that's all we got is the hearts and minds of people, and the fear of being exposed, that to your inequities, and things like that, or disparities that exist within your institute. There's no institutional reimbursement for improving the outcome of people of color or marginalized communities.
Wow.
I've had the privilege of practicing in some places that are majority, and the majority of the people that come through there are poor white people,
Mm,
and they're treated like crap.
mm,
I mean, so this is about power,
mhm.
status, and then on top of that, you layer color and race and the institutionalized disparities that exist, that we know exist in every institution in this country. Who
Right.
cares? The government has no program out there that incentivizes
Mm,
a hospital system or a doctor to
mm.
take care of people. And all people, yeah,
Yeah.
we want you to have meaningful use and all these other things.
Yeah.
But the reality is not translating to the bedside. It's not being translated. I want to just say one other thing about what you just said.
Okay.
What you said prior. Then there's no war. War is costly.
Mm,
There is
mm,
a race, however.
mm,
There's a race for more money. There's a race to grow.
mm.
There's a race if you're in some of these regionalized nonprofits. You don't have to look very far in Virginia to find the big brand names,
Yeah.
okay? For what? Dollars.
Mm.
They grow as nonprofits to basically do what? It's scale. You got all this revenue, and hopefully you can get all this money in, all right, and not spend more than you bring in.
Okay.
Okay. So you go out and you try to create scale. You create scale because now you can negotiate harder with the payers and the employers in your area.
Yeah.
Oh, these unless you follow this stuff, the average person wouldn't even think about or know this. But this is the dirty little secrets in healthcare.
Mm,
So when you talk about the inequities and you talk about the disparities,
mm,
to get beyond the issue of institutionalized racism and healthcare disparities and all these other things that we know exist,
yeah.
to get beyond that, you have to start thinking about, you have to take it to the level of burden of disease, because
Mm,
you're going to see a higher burden of chronic illnesses among African American people and BIPOC communities,
mhm,
Native American, Hispanic, and Black.
mhm,
Okay,
mhm.
hypertension. Okay, not so much hyperlipidemia, but not so much cigarette smoking, but hypertension, obesity, and diabetes. Those are the kind of the big three
Mhm,
that are you're going to have a much higher prevalence of that in
mhm,
BIPOC communities than you have in other communities. Now, let's start breaking it down to the social determinants of health:
mhm,
where you live, food insecurity.
mhm.
You and I talked about that in prep for this.
Yeah.
Housing insecurity.
Mhm,
Okay,
mhm,
financial insecurity.
mhm, mhm.
Okay,
Exposure to racism
expose
and
all of those
the
things.
mental health impact of that
Absolutely,
alone.
all of those things that we know create these disparities.
Yeah.
Food deserts within communities
Yeah.
where there's a liquor store on every corner and a church next door, but you can't find a Whole Foods. That's not part of their business model. You're not going to find Whole Foods, not going into these areas, because Whole Foods decides where they're going to put their businesses based on what the demographics is, like most businesses would do.
Yeah.
You know, and so I think, and again, I don't think it's necessarily Whole Foods issue to solve,
Sure.
but we have to think about these types of examples
Mhm,
when we think about why is it that the disparities exist. So then let's just say, okay, let's just make everything neutral. Okay, we don't have any racism, we don't have any, a bias or unconscious bias or any of that stuff in healthcare.
Right. Right.
But if Miss Jones, who comes in who's white,
Mhm,
and she weighs less than half than Miss Jones, who comes in that's Black,
mhm.
Miss Jones, who comes in Black, is probably going to be diabetic, probably going to have hypertension and be susceptible to whatever complications or whatever there may be related to whatever her illness is,
Yeah.
relative to the white Miss Jones, who doesn't have those issues. You see how that, so let's just wipe that away, but then just the burden of disease. But then now let's just put it back in there,
Mhm.
the unconscious bias.
Yeah.
The Black Miss Jones comes to the ER with a heart rate of 200, and she sits down and mild heart attack, borderline heart attack. No, you had a heart attack. Okay, you need to go see a cardiologist.
Yeah.
All right. Well, what if she just sent home and told her, stop taking caffeine and drinking wine?
Mhm.
So it gets to a lot of issues, quite frankly, that we need to address as a society when we start thinking about these things that determine health outcomes.
Yeah.
And it's not about just saying, and it really gets me when people say, oh, well, they should just do better. Really? Come on. That is so narrow-minded.
Yeah.
And that's part of the problem because, it's the, if I didn't experience it, it didn't happen to me, it doesn't exist.
Right.
That's what you'll get from a lot of healthcare providers. I literally kind of stopped engaging online in so-called professional forums, because if you hear some of the rhetoric, certainly in the last 8 years when Obama was elected, then we transitioned over to Trump.
Yeah.
And all of the things that have now been exposed in the society that we know to be true regarding racial inequality and all these other things, and
Right.
police brutality, et cetera, et cetera. It's amazing to hear that the very people you think ought that when you go see them for that ablation and that heart surgery, you'd be surprised some of the things they think about you.
I'm not surprised. I'm not
No,
surprised.
you couldn't be surprised.
No, because I have been asked over the course of dealing with, let's say, that first chapter in surviving a heart attack, surgery, treatment, so on and so forth. I have been asked going in to meet with other practitioners, oh, are you educated in medicine? No, because I know my body. No, I've been asked, where did you train? Where did you get your education? What are you? To validate my ability to intelligently express not only what has happened to me, what my treatment has been, but prognosis and the like. So yeah, I've heard it all. And I'm a miracle, and I'm a miracle because of Dr. Cooper. I happen to be one of the exceptions that have made it through, okay, what we won't call war, but certainly a conflict in moral obligation and professional acumen to treat me, to give me the highest level of medical treatment in spite of my perceived and my inherent differences in living with cardiovascular disease. We could go on for such a long time, but I want to leave us off with answering 3 questions, if you would, and then I want people to know how to get in contact with you to continue this conversation of the very important work that you're doing. So one of the motivations behind having this Zoom series is making sure that we address 3 factors. That is a myth, mystery, and management of cardiovascular care. Can you give us one? First thought that comes to your mind, what is a myth that we can blow up today as it relates to cardiovascular care?
Here's my big myth in cardiovascular care. And if you look at, and this is where, I sort of jump off of what the professional people say, which is if you look at the mortality and morbidity from cardiovascular disease over the last 20, 25, it's actually gone down.
Okay.
And the myth is, the myth, quite frankly, is that somehow that has, to some extent, been because of the improvement necessarily in health of Americans. Myth, wrong. It's because of the improvement in drug treatment of chronic illnesses. And so if you look at, and let's do the research yourself. Don't rely on me. I challenge you to go out and prove me wrong.
Sure.
So if you look at the survival and mortality from cardiovascular disease over the last 20, 30 years, it's actually gone down. Done a good job. But if you look at the cost of medications and interventions and new toys and devices, it's done this.
Okay.
Is there enough in the middle to offset the overall? Is there enough of a delta between the cost of new toys and interventions and drugs and the actual decrease in utilization? Because I think, do we really know the answer to that question? All right. Okay. So the myth that somehow we're improving, and if you think about this is at the same time that we're discovering that we are probably underestimating the number of people who are diabetic by on the order of maybe 50 to 70%. Okay. You may get some number like 35, 40 million people with type 2 diabetes. A lot of people think that number is probably closer to 80 to 100 million people. Okay. All right. At the same time, obesity rates have gone up.
Okay.
So the myth that we are somehow injected into our society, and that all the things that we talk about, these social determinants that lead to disparities in comorbid conditions. No, it's that the drug companies have done a fantastic job at creating drugs to offset your bad eating habits.
Wow. Big mystery. What's one of the biggest mysteries that we can expose today around cardiovascular disease and care, or care?
Yeah, here it's less of a mystery as much as it is going to be one of those things that's really going to crack, or really going to have a huge impact.
Okay.
And that crack is going to come. See, because if you think about your heart just as in its very purest form, we really don't know how long, if you put that into an isolated system, how long your heart could actually last. So two things. One is, most of the things I just talked about, one of the drugs that we've just talked about are treating things after they occur, or stabilizing them, okay, or putting your heart in a little bit better functional capacity based on some of the things that are going on there. Once we learn how to completely prevent that, that's number one. And second, even bigger, reverse it. Now, we know to some extent how to prevent and to reverse.
Okay.
And here it is. Okay. We know that people who adhere to a strict plant-based diet, okay, and who can monitor, quite frankly, their intake of refined sugars and things of that nature in the same context, we can actually show that you can reverse cardiovascular disease. Now, here's the trick, however, is that although the power lies within all of us, the people who are going to figure it out are going to be the pharmaceutical companies, and we're going to add another drug, okay? And so that's going to be very key. The mystery to unlocking the brain, for example. We're sitting here talking about the heart, but we've learned so much about our brain capacity and the power of the mind. And I mean, that research, sometimes I just have to read it to blow myself away and understand, what we're looking at here, quantum physics and nanotechnology. I mean, it is going to be a revolution, but the mystery of how we can, in this bombardment of environmental inputs and our own choices, drinking, smoking, eating, whatever, and enjoying this body that God gave us. How can we unlock the immortality that, quite frankly, is built in our bodies? Big mystery. Cancer. And you know the story, my mom died of cancer. And I saw this data came out, maybe it was like a year ago or whatever, a year before. Today, there are over 20 million people in the United States that are living with cancer. Living with cancer. And so the key there is living with. They're living with diabetes. They're living with hypertension. They're living with it. They're not dying from it. They're living with it. I mean, that is truly amazing. I mean, cancer in my business, in heart business, if you somebody coming to us with cancer, if it wasn't like just a simple prostate cancer or something, that was like hands off, because they're going to die from cancer. I operate on people on cancer drugs every day.
Really?
Just like normal people. Yes. We have to modify, our interventions based on perhaps, their treatments. But yes, it's very, very common. You have people living with cancer. So what is that telling us about this human body? So the mystery of the human body and how we can unlock our immortality is going to be very intriguing. It won't come in my lifetime. I got another 35 years. I'm claiming that. Okay. I'm living to 90.
I'm claiming it for you.
Is that 45? Like, I got 45 more years because I'm living to 90. I claim that already. All right. But that to me gets me going in terms of how I think about being in this profession of medicine and healthcare and science that I am in. But also on the other side, and why we created our company, all the things you just talked about. It's about providing access to information, access to people like me, easy
Yeah.
access to a specialist,
Yeah.
somebody who can help you navigate
Yeah.
these problems.
Yeah.
Because unfortunately, our current systems don't really work in the favor of the patient in terms of helping you with that.
I love that part about Primo, because you mentioned that you also offer health coaches, because you are the first doctor I've ever heard to make that profound connection between brain health, hello, leading all of the other critical decisions that we're making about what goes into our bodies that could prevent cardiovascular disease, that could prevent cancer, that could prevent other mental health issues. Why do we make the decisions that we do? What drives it? And then who can hold us accountable? Well, first of all, provide us with the education that we're not getting from healthcare,
Right.
and then provide us with the education and information that we need to make more informed decisions. And so these changes are happening. They're happening, but they're not happening soon enough. I think one of the things that I was most shocked about my recent trip to the Middle East was seeing the McDonald's, KFC, Domino's that were in the airports in Dubai and in the Kingdom of Bahrain on every corner. And I thought, holy, really? This is America's contribution to one of the wealthiest countries in the world. And here we are spreading foods that how are those foods going to impact the health outcomes of those people in the Kingdom of Bahrain? It hurt my heart. I didn't think, oh, McDonald's. I thought, shoot, of all of the things that America could have done to influence another country. And as I come back to Dubai, I see all of the people that are morbidly obese in the airport, packed into McDonald's. That line was around the corner inside the airport going to McDonald's. So why do we make some of the choices that we do? And how can we distribute the information to make better decisions more efficiently? I love that that's one of the things that Primo Healthcare is providing, Health Partners, I'm sorry. And I want to talk about that a little bit more in just a moment. And maybe we can wrap that up in the third of the M's, and that is management. And how specifically, let's talk about that. Let's talk about specifically how Primo is helping more of us to manage our health concerns, as well as our diagnoses and treatment to improve outcomes for those who live with cardiovascular disease.
Yeah, so we, I'll just say it again, Primo Health Partners, and you mentioned earlier to get a hold of us, primohealthpartners.com. Just go to the website.
Great.
Log in, give us your information. We got a lot of wonderful stuff coming down the pipe. And so as a specialist, I got into this thinking that, there's so many people, I get calls every day, and I have for years, similar to like, a friend of a friend, your friend Tara, who I've known for years, call me up and say, hey, Coop, you mind talking to? Yeah, absolutely. I get this every single, I still get it. So you're now, you were in the mix then, and now there's been literally probably hundreds, if not maybe thousands since 10 years ago that have reached out to me. So I said, really, what I found is that people want to talk and have real serious conversations with doctors, and very specific conversations. And I also observed over the years as I would give talks, there was always some person in the audience who wanted to personalize their question. And that's not a fault. This is because they had something, you touched on something that touched them.
Yes.
And so as I've sort of begun to kind of think about it, I said, people really want to just have serious conversations with doctors about their healthcare, out of the setting of the rat race, the volume race in the office, the used car salesman pitch, or whatever it is that you're going to get in a doctor's office in a lot of cases. And they really want you to kind of have an in-depth, and they, you can get a second opinion. You just go look it up on all of the major academic brands around the country. And they're going to give you a nice report from some doctor that you'll spend 30 minutes with. They're going to give you all this academic stuff, blah, 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 blah. Yeah, and we could do that for you too, but we really want to have a more practical conversation. All right, about your, you've got heart disease, if you've got cancer, or you've got an orthopedic urologic problem, GYN problem, or something major like that you want to discuss with someone outside of your normal, chain of healthcare services.
Right.
And so that's us. And we want to provide that access to just the normal people. Okay. And then we take it a step further there. We want to be your partner. Okay. And you just think about this is that, we're trying to coin the right term for it, but essentially just think about it because as a concierge telemedicine practice. Okay.
Mm-hmm.
So you can pay us on a subscription basis, a nominal fee per month to have access to any of our specialists.
And how much is that, Dr. Cooper?
It's $99 a month.
Okay. And what do they get?
$100 a month.
What do they get for that $99 a month?
So you can have a visit now you have to have the first visit with us to establish care. So that gives us the opportunity to pull your records into our system, talk to you about, whatever, all the problems that you have. Now it's probably going to be very, very system focused because you may be talking to me about your heart, but you may be able to come back to us 2 months from now. Now if you're a woman, you may have a breast problem or a GYN problem. And you say, well, I don't need Dr. Cooper, but this is all in my record with PRIMO Health Partners. I want to talk to one of the GYN doctors.
Okay.
You dial in, you request an appointment, 48 hours, we should be able to get you that appointment with that specialist to answer those questions. So the $99 gives you on a monthly basis, one visit with any of our providers to talk about anything that you want as it relates to your health. And this is all done in a secure, HIPAA compliant portal that we provide through our website. And once you establish that care, you have access, and it's transferable. You can if you got a family member or something like that, we have to go through the system. We have to do it the right way and adhere to our regulatory environment. But you can go through that. You can transfer it to a sister, a brother, father, husband, wife, somebody like that because for us, it's just about you having the access and having it in as timely of a fashion as possible. So that's our partner program. Once you sort of come in for that initial consultation or second opinion about whatever, and then we have the health coaching. Okay. All of our coaches will be certified. Largely, they're going to be certified through IPEC, which is the Institute for Professional Excellence in Coaching. It is worldwide recognized as sort of the standard. I'm actually finalizing my coaching certification with IPEC. And so a lot of them are going to be IPEC because they have a certain technique that I like, which really gets to the individual's, the core energy that we call it, of what makes, like you said, what makes us tick, what's happening here. And our coach is about, and it's not about really holding you accountable. It's about helping you hold yourself accountable, teaching you how to hold yourself accountable. That's what health coaching is. But if you want that partnership, we talked a little bit earlier about, a lot of the stressors in our society that force us to kind of look for comfort, things to comfort that stress: overeating, cigarettes, drugs, alcohol, whatever it may be. So part of our program, we have an exclusive arrangement with Tailored Wellness based in Atlanta to provide mental health counseling.
Okay.
So for those people who need a little bit more, then, a little bit more of that, okay, I'm going to hold you accountable kind of thing, that's counseling. Okay. Then we have the health coaching. Okay. So those are kind of the 4 tiers: the specialty-based opinions, the partnership program, mental health counseling, and health coaching. We're also looking at adding, we just might as well accept that it's out there. Okay. It's out there and it's evolving, and that's medical marijuana certification. We're going to be adding that. We're partnering with another company who provides that. Okay. Because we anticipate that over time, a lot of our patients are going to have chronic diseases, cancer, arthritic problems, and other problems that potentially could be helped by having medical marijuana. People are going to need a trusted source that they can go to.
Absolutely.
To get the proper evaluation and certification. So we're going to be adding that. We're going to be adding weight management. Okay. There's some exciting things happening out there with some of the drugs that have been discovered for treating type 2 diabetes mellitus. A lot of those drugs, GLP-1 inhibitors, are actually fairly good at helping with weight loss. And so now you have some of them that have gone on to get FDA approval specifically for weight loss. And some of the results of those are pretty dramatic for those people. So we want to and that's why we call the company, it's called PRIMO Health Partners. Because although we may be going out there to provide you with that high level interaction, we want you to be able to we want to be your source. So we don't want to shoot this over to some supplement company that's some, jackleg on Instagram or some other social media site that's telling you that they're going to cure your. No, we're not going to do that. We're going to approach this from a healthcare perspective, and we are going to help you navigate a very complex. So you asked earlier, how do you do it? It's gotten so complex and complicated that it's hard to do on your own unless you are a healthcare provider. I can call up anybody. I got so many doctors I call right now if I needed them, and they're going to respond because I'm another healthcare professional. But that's professional privilege, quite frankly, to have that access. We want to be able to have people who come on with PRIMO Health Partners to have that kind of. Now, and here's the other thing for doctors: we're not trying to be your doctor, okay, per se.
Okay.
But if the doctors want to challenge me, because your patients wouldn't be coming over here if you were giving them everything that they deserved and needed.
Well.
Okay. So let's keep that real. Okay. You want to keep them in your practice, do the right thing. Stop chasing the volume.
Yeah.
Okay. Start taking care of people. So we exist because there are holes and there are deficits in the system. And a lot of those holes have been filled by things that aren't very helpful or healthful for patients. Okay. We fill a lot of people with a lot of selling snake oil. We're not selling snake oil. Yeah. All right.
Facts.
And so
facts and education that other doctors are not taking time.
PRIMOHealthPartners.com. Oh, we're adding also one other component to what we're doing is we're going to help. One of our major targets for who we're going after is we're going to put our program should be completely staffed, certainly with the big cancer, orthopedics, urologic, GYN, heart, those kind of neurologic issues. We should have all those specialists on board by the fall because we want to have our package together. We're going to be targeting small, large businesses, whatever, to add us on as part of their benefits package. Now, what they're going to say, well, the insurance companies that they got on there, they're going to say, oh, well, we offer that. No, you don't. Not this way. You don't. You got the nurse line that you can call. And look, let me just tell you something. I've been in this game for 30 years. I know what you do. Okay. So you can't, I'm not going to use that word, but you can't give me that runaround that you were doing, because if you were, I would not exist. Okay. And so I'm putting them on notice. We are out here. We're not going away. We are watching the regulatory environment for telehealth. COVID really opened that up. And quite frankly, it's given us the opportunity to be able to do this. Okay. And we see value here. We see a couple things. One is we're not about volume. We're about access. Okay. All of our providers are going to get paid. They have a deal with us. Okay. And that deal is they're going to get paid a percentage of the people that they see. It's not about volume. It's about providing you with access. Okay.
Yes.
Now, and then the other thing for our providers out there, they share in the profits of the company.
Oh,
yeah. Okay. You have to go out there and ask another healthcare system or your employees and people. Some of them have profit or ESOPs or profit sharing program. Right. A lot of them don't. And the vast majority of them have dumped the old pension plan. Okay. Wow. So we're looking at this and we want to take care of everything. I want happy doctors. I want you to get doctors on our thing that are like me. They can sit and have a real conversation with you, unencumbered by emotions or all kinds of other crazy stuff, but full of the love for you as a person and humanity that you bring, and the fact that you want to try to get better. Last thing we're adding, I talked about benefits, but we have a pending partnership with a benefits advisor, someone who can help you when that benefits time comes around. Look at what you're being offered. Look at all of the things that you got going on from a healthcare perspective, and say, hey, here's some of the things that you need to consider. These are professionals. They do this for a living. Now, here's the other thing I want to point out. This is my last thing on this. Okay. People say, well, here's the first thing that Americans will ask: do you take insurance? But right now, I don't. Okay. But we may be moving in that direction. Okay. It may be a matter of survival for us. I'm paying for this business completely out of my pocket. That's why I'm all over the country working. And that's okay. I'm having fun. But no, we don't. But I would challenge you to do this. Just hold back on one of those pair of expensive tennis shoes that you all are buying. I went on the website the other day and I saw a pair of tennis shoes on there with Michael Jordan's name on it for $35,000. Really?
Insanity.
Now, Michael Jordan's funky foot has been in there playing basketball, and you're gonna pay $35,000 for it, really? And then you're gonna talk to me about paying me $500-600 just to evaluate you and give you access to all of this other stuff? $100 a month,
and
really?
potentially save your life.
Really? I mean, so let's get away from that. Okay, you need to invest in your healthcare, and if you think that your insurance company, your doctor, your hospital, your pharmacist, or anybody else out there is going to make that investment on your behalf, you are just an absolute fool. It's not going to happen. You have to do it. Okay. Yeah. And you have to begin to think in those terms that health is your wealth.
Yeah.
Health is going to get you out of the realm of food, financial, housing insecurity, and all those other things. It's going to give you your health is going to give you the opportunity to level the playing field for yourself. Dr. Austin, this has been a fantastic conversation. Love you to death, girl.
It's been wonderful.
Haven't seen you in 20 years.
I know.
Get at some point.
It hasn't been 20 years, and I don't think it's.
I know. I'm just kidding.
but listen,
I can't reach you most of the time. You're halfway around the world.
We are certainly surviving a pandemic and have gone through, climbed many mountains since we did last see each other. So I am here, and I am so glad we've reconnected, and I'm so grateful, not just myself, but I know the American Heart Association and everybody who tunes into this recording later. They will be transformed not only because of who you are as a practitioner, but because of who you are as a human being. Thank you for being with us today. And thank you for continuing to do the work that you do on behalf of myself and other survivors of heart disease and survivors of a broken healthcare system. We thank you. And please tell everybody one more time where they can get in contact with you to access the incredible services that you're providing through PRIMO Health Partners.
Yes, it's PRIMO, P-R-I-M-O, Health Partners, all one word, primohealthpartners.com. And you type that in. Please go on there, sign up just to get so we have your information. Because as we add on more services and more programs, we're going to be reaching out to you. Give us your email address. We're not going to bombard you with a bunch of crap. We're only going to bombard you with stuff that we think is important for you to know. primohealthpartners.com. You can connect with me directly on all social media at Dr. Coop MD. So you can find me on all social media, my YouTube page at Dr. Coop MD, LinkedIn at just put it in there and you will find me. PRIMOHealthPartners.com. It's all very consistent. Thanks to my good friend who advised me on this years ago, Yewande Austin. So yeah, just connect with us, stay up to speed with me and what's going on, because there are going to be a lot of other things that are going to be coming down the pipe.
I'm so excited. I'm so excited for you and so grateful for you bringing this energy into the healthcare space, because we're seeing more of the inequities because of COVID that exists within healthcare than ever before. And of course, you have just shined another light on it, that so many people are not aware of the uphill battle that we're fighting. So we're so grateful for you. And I'll make sure that post-edit, I throw up a page with your website on it so people don't have to struggle looking for it.
Absolutely.
And we look forward to continuing these conversations and look forward to seeing what PRIMO Health Partners is doing in the future. Well, Goodbye for now.
Thank you so much, Yewande.
Thank you so much for joining us, and until next time.
All right. Bye. See you soon. Bye-bye.
Hold, stand by.